Started as Abdul Ghani Sharskiro has said, we have several of these programs, and in particular for therapy. Uh, Unfortunately, it's always in high demand. We just finished closing one for November uh, on actual nuclear medicine therapy. It's a laboratory based training program. It's about 6 days. Yes, louder. I can't. I have only two children, and my wife yell. She says something, they come close. Can you make it louder? Yeah. Sorry. So I think we have a 6-day course where it's focused on both alpha and beta therapy at Anderson. It's sponsored by IAEA and the Argonne National Laboratory. But it's always limited to 25 people because we only have so many physicists who can have the laboratory portion of the test. The laboratory portion is actually calculating the doses, drawing regions of interest, treatment planning, essentially. But it's for alphas, betas, and it's divided between the major favorites. We have lymphoma, thyroid cancer, beta and alpha therapy, prostate cancer, breast cancer, soft tissue sarcoma, and we also give lectures given by the medical oncologist when pertinent, radiation oncologist when pertinent, and then the subspecialists, let's say like in immunotherapy, things like that. So Abdul Ghani told me, so the coming year there will be 2 more, so just keep an eye out for these A&L courses, Argonne National Laboratory. But that's the good news. The bad news is it's in Houston. Houston is a oil town. It's not like New York City where it's Broadway and stuff. Well, we have Broadway, we have NBA, we have NFL, but it's not as fancy as the other cities like San Francisco, Chicago. It's just Houston. The only good thing there is if you like space travel, the mission control is very close to NASA. Mission control is close, so you can go there. They fly them out of Cape Canaveral, but the control is down in Houston. That's why when the astronauts have a problem, they say, Houston, we have a problem. And then if you go there, if it's at the right time, you can talk to the astronauts in the space, the laboratory, the International Space Center. The problem is they only ask the children to talk to the astronauts. And they always ask the same question, how do you go poo, how do you go pee in space? That's usually the same question they ask. But anyway, shall we, everybody settled in? Shall we go forward? Beta therapies for palliation of skeletal metastases. This is a big part of our practice, and I hope it becomes a big part of yours. I like to emphasize the therapy part of nuclear medicine because it's really the best part. It allows us to do the diagnostic studies, to allow us to give therapies, repeat the diagnostic studies to assess for response or non-response to therapy, and it allows us to stay in touch with the patients, gives us the consultations, etc. Plus, it actually keeps us active in multidisciplinary care. We have an inpatient versus an outpatient therapy side, which makes us pertinent to practice. So again, this is to treat painful metastases. We treat them because they are the most common tumors of the skeleton, as was said before. It's nearly 2/3 of them are breast and prostate cancer. The lung cancer patients for therapy, we do not treat them quite as often directly, but mostly for breast and prostate cancer. If you do have a pediatric population, you may see some of the primary metastatic skeletal primary tumors of the bone. It is very important to treat them because it affects patient prognosis and quality of life. Patients who are terminally ill does not mean we cannot give them palliation or remove the pain, because we don't want them to spend their last few months or year in the hospital. You want to make sure they can have time to take care of their affairs and be not in pain to be able to go about doing their stuff. It is actually a lot of times more for the relief of the immediate family and the patient's own conscience, because they become a burden to their direct family. So we're talking about quality of life. There comes a time when we realize many of these patients are essentially incurable. So if we detect them accurately and plan the treatment, we avoid the emergency situations where they have spinal cord compression or impending fractures, which can be avoided. What do I mean by impending fractures? Instead of waiting for the fracture to happen, because they're, let's say they have metastatic breast cancer, if you fracture the hip, they may spend their last few months in the hospital. So if we identify an impending fracture, usually with plain film, they could put a rod in and stabilize it or radiate it if you need to, and then they don't suffer those fractures, which will debilitate them for several months. They will be bedridden, spend the rest of their time in a chair or a hospital bed is not very pleasant quality. So there are many new therapies which we can give for skeletal metastasis to avoid these things. The ones we use obviously are radiopharmaceuticals. You can give them in combination with the bisphosphonates. Usually it's the endocrinologist who give them. They could be denosumab, the rankle. It depends on the type of metastasis. We always want to use the local radiation techniques because it's very fast. If they're very focused, radiation therapy could be done. Most metastatic diseases are not usually treated with surgery in our institution unless they are quite small in an accessible area, which is, and the surgeon agrees to do it. Usually it's in combination with interventional techniques where they can embolize, shrink down the tumor, treat with anti-angiogenic agents to further shrink it down, radiate, and then take it out. A lot of the new techniques are done in interventional radiology, radiofrequency or thermal ablation. They put a probe into the tumor and then essentially cook it. So they ablate it locally. So you can use this in combination with the radiopharmaceuticals because the radiopharmaceuticals essentially radiate all of the tumors, but the ones which are very symptomatic, because ours don't relieve the pain right away. It may prevent the occurrence of pain from occurring later on, so that's an important thing to think about in your strategy. Usually you'd have to, we have dedicated groups which address this, but they're usually addressed in our multidisciplinary care system, so you need to have somebody at least represent nuclear medicine or some of the radiologists. For us, it's mainly the radiologists because there are far more of them than us. So that is part of the reason why we work with the radiologists to ensure that we are represented in all the areas because we can't cover all of these areas. The easier thing on how to think of putting in therapy for skeletal metastasis is bone scanning. The bone scanning technique is actually our upfront technique, and its metabolism and biodistribution is fairly similar to many of the known clinically used tracers from as old as P32. Samarium or Quadramet is approved in the US, as is strontium-89 and radium-223 dichloride, which we will address later. Radium obviously is an alpha emitter. Strontium-89 as was approved earlier, followed by samarium, and we usually use these tracers in the clinic. It's used, it's approved, it's covered by insurance. They always ask us, should we use sodium fluoride or MVP? We certainly use sodium fluoride in settings where we're in a clinical trial, where we need more accurate quantification of bone turnover. It depends on the type of studies you're doing. The sodium fluoride PET scans are certainly faster, but it will occupy the PET camera. So our PET cameras are nearly always occupied by the FDG studies. We have far better capacity in terms of MDP because it's technetium. You have a longer half-life. It's available anytime you can draw it. Sodium fluoride you have to pre-order or unless you have your own cyclotron. For us, we have our own cyclotron, but we use it only for cooking, not cooking, but making the research tracers, some longer-lived tracers. We get our FDG from a nearby facility which we're partners with. So we're business partners with PetNet. So they give us the doses. Our first injection is usually at about 5:45 a.m. It's the most popular one because the lymphoma patients are well. They get injected at 5:45. By before 7 o'clock, they're going to work already. So they like those slots. The 6 a.m. slot is the most popular slot for us. So this is what I showed you before. Skeletal scintigraphy is the gateway or the technique by which we identify osseous metastasis. And it is the technique by which we have to perform prior to using all of these beta therapies because, as I said, they follow the similar pathway for distribution, and calcium analogs, certainly like strontium 89 chloride, follow a similar biodistribution in the bone. That is, metastatic lesions retain these tracers longer than the bone. Okay? We certainly use radiography in evaluating these lesions, but in the presence of CT and all of our gamma cameras, it is far easier and quicker to look at lesions which we are treating or symptomatic areas with CT. That's our preference. Fluoride PET, as I said, is not a standard for us. It's part and parcel of multiple trials which we use. And certainly you can do the trials in combination with FDG. So we have to remember the beta is what we use for most of these therapies, as well as the alpha. There's an essential difference to them in the sense that they are therapeutic nuclides. They can deliver far greater radiation, more penetrating radiation in millimeter distances or micro, very small distances. The alpha emitters are obviously of a higher energy. This is the half-life. Samarium has a much shorter half-life. 2 days. Samarium is the other end of the spectrum, so it's a 50-day half-life. This is sometimes comes into play with your choice of tracers. As the longer-lived tracers you might not want to use in patients who are in particular terminally ill. As you may not want to do it, but you have to consider the half-life. There are some early studies which showed in pilots that maybe the shorter lived tracers may have quicker effect, but the longer term follow-ups did not show that. The bone surface to red marrow deposition or distance in which these tracers irradiate is actually interesting in the sense that it is different for the betas and the alpha. That is, the alphas tend to not irradiate the marrow as much. The beta emitters obviously have fairly high energy, but not as much as the alphas. And the range, as I told you, the range by which they deposit the radiation they deliver is much longer. So there is a larger bystander effect. So these tumors or the bone which picks it up will irradiate a larger volume or distance from the site of deposition at the bone, but at the same time may also deliver more radiation to the marrow. So there could be greater toxicity to the hematotoxicity with the beta emitters versus that of the alphas because the deposition is very short. There's also a difference in the energy transfer. The alpha transfers a far greater energy, so it's more deadly. It's a larger mass, and it can kill the cell with solitary or a few hits. A few hits from the alpha can kill the cells, whereas with beta, you need far greater numbers of deposition of cells before you can treat or kill them. Lab studies have shown that they could kill against resting cells, the alphas, whereas as well as radio-resistant cells, but it seems that the beta emitters are not as effective in this setting, at least in the laboratory setting. So for prostate cancer, for us, it's been a big part of our practice because most of our bone scanning is prostate cancer. It has surpassed lung cancer as the most common cancer in men and the second deadliest cancer in men. So most of the morbidity and the mortality happens when they become metastatic and castrate resistant. Its number one site of metastasis is the bone, and when they give them anti-androgen therapy and the PSA begins to rise up, that means it's castrate resistant, right? If you remember some of the famous people who who had prostate cancer, like General Schwarzkopf, Rudy Giuliani, the mayor, we used to call him Il Duce, very tough guy. But when they treat them with anti-androgen. So you can see they get heavier. It's like being old. They get puffy cheeks because of the steroid effect, and they don't have the beard anymore. This is the anti-androgen effect. So these drugs, androgen deprivation therapy, is quite commonly given. It's nearly all patients get it. It's usually in older patients, and again, the rising PSA is the first indication of resistance. And this is essentially, if they have bone metastasis, it's an incurable condition for now. The median survival is about 2 years, so they've been longer than 2 years or less than 2 years. So that's why we need to treat them, because the morbidity from bone metastasis is very high. The marrow failure happens, that is, you don't mount, you become thrombocytopenic, your platelets go down, you become susceptible to infections. You can have pathologic fractures, cord compression, you get paralyzed, your legs become numb, you can't walk. So these symptomatic skeletal events, or we call them SREs, skeletal-related events, can be treated by more chemotherapy, sometimes with the newer drugs like immunotherapies. You have to treat the immediate symptoms with opioids and nonsteroidals, but again, there are the GI effects, the nausea, the vomiting, constipation, and a lack of, you become disoriented when you have this. As I told you, you can do XRT, EBRT with solitary sites, but with multiple sites, which is not unusual, radionuclides come into play. So that's the important thing. So it is up to us to be out there to tell the referring physicians as well as the oncologists that it could be part and parcel of their therapy for their most common patients, which come in as patients who have marrow metastasis. Again, it's the main cause of death in resistant prostate cancer. So strontium chloride, have you guys used strontium? No? Strontium it's very easy. It's one injection, clear, colorless. It's like calcium. This is the way we explain it to patients. It localizes to the blastic areas, the high or hot areas on the bone scan. 50-day half-life, very strong beta range, and it has a range of 2 to 4 millimeters. So when it is disintegrating, right, it emits its energy in a very short range, so you can tell the patients they're not going to pose a danger to people around them. So their kids can't tell them to hold their sandwich to warm it up for them, things like that. They're not going to glow in the dark. The dose is more or less a fixed dose, 4 millicuries. Most of it is excreted in the kidneys, just like the bone scan. You look at the bone scan, you see the bone, you see the kidneys and the bladder. So it's radioactive. So make sure they don't write their name on the bathroom wall Homer was here when they're going pee, right? Men are dogs, you know, what can I tell you? They raise one leg, they can go anywhere. Can't do that. They have to flush and they have to wash their hands. Washing the hands is like us. You have to sing happy birthday to you, happy birthday to you, happy birthday, and you use the interlocking thing like what we use. You can look it on the web. Happy birthday to you, so it washes into the sink. And it's another reason not to swim in the river because everything goes down into the sink, etc. Especially not in Houston or in New York. Don't go to the Hudson River. GI tract, same thing. You do number 1, wash your hands. You do number 2, wash your hands just as well. Very important. Okay. So as an indication, it is an adjunct to or as an alternative. So you can give it with external beam radiation therapy. You spot weld with the radiation therapy, and the general distributed bone mets can actually suppress or delay the occurrence of pain from these other sites secondary to metastatic prostate cancer. You have to make sure you confirm bone metastasis. You can use one from 1 or 2 months. You have to have a bone scan, which shows you that these sites where they have pain have uptake. You know, they have lumbar or low back pain, but there's no uptake. You might not want to do that treatment. You can radiate, but if he has other sites, and you have to question. I have a harder time eliciting the history from men, and I think it's also cultural. It depends on what part of the world, because 80% of our patients are not from Texas, so they're from different parts of the world. Certain parts of the world, the men don't like to share their symptoms. They're very like macho, so it's not very masculine to be whining and complaining. So you have to be very thorough, because you need a baseline to record the baseline on how much they improve. You have to do a CBC. Platelets have to be around the 100,000 K range. If they're not, you can do a platelets transfusion. You can have them have a platelet transfusion. The leukocytes are here. You'll get these as a PDF. Platelets will get depressed, 30% typically. The good thing about the beta is you're used to beta therapy. This is like iodine. 4 to 6 weeks afterwards, you give them a high dose, a couple of 100 millicuries of radioactive iodine. The platelets will go down, and then they may go back up. You monitor it. If you need to, you can give them an infusion of platelets. Since they are prostate cancer, they could give them cytotoxic agents at the same time. But then you have to tell them that you will be giving something which will deliver hematologic toxicity. So the medical oncologists need to be coordinating this with you. And again, you have to make sure they are aware. And, you know, we have leaflets to remind them. You have to tell them, you have to remind them, and you have to give them something. Usually I give it to the wife, the list, because they're good at, you know, making sure they're there, keep an eye on them, and that's what usually happens, or the immediate family. And so that's why they will adhere to the radiation safety, because they will be living with people, etc. So these are the usual questions. Can I fly home when I give me the strontium? Yes, you can. You can do it. We give them a one-page explanation of what treatment they get, just in case they set off the detector in the airport. You can't set it off because they set them at a lower level, and then they'd have to be stopped, etc. But don't put this in people you don't like. Don't put it in their pocket, and then they'll be in jail for a long time. It can relieve pain for a long period, usually not as long. These are very unusual cases for up to a year. Patients you have to choose must have some pain and reasonable life expectancies. Our experience is around the 60% range. The response rate is 60%. So more often than not, they could have response to pain. It's about a week to 2 weeks in our experience. And the mean for us, as I said, is not up to 12 months, but more like that, between 6 to 8 months. and then you can retreat. Patients need to be aware that you can have a flare response. It's 1 or 2 days. You can have a little bit more pain, particularly in the site they have it. It could be associated with a much better response, but just because a patient does not have flare does not mean they're not going to respond. The good responders usually have a hotter bone scan. They have a greater amount of uptake, but not a super scan. Super scan, they usually tend to be very advanced. You, as much as possible, want to treat them early instead of very late. And then you can retreat about 3 months. So you don't have to wait 6 months. They get a good response and they're beginning to get more pain. You can actually retreat at 90 days. But you have to make sure the platelet counts are good. And for us, what we actually do at 90 days, if we're going to retreat, you repeat the bone scan. There are new sites of pain which have very high activity. The primary reason is to make sure we're screening for any possible pathologic fractures or impending fractures, which could happen. Because then we could irradiate those sites or put a rod in it if we have to. You keep them going as long as you can in a comfortable situation. Strontium can be delivered with concurrent chemotherapy. Again, it can delay the onset of new sites of pain. It has been given in double or more than double doses. Dose escalation trials have been done to see if it can have a survival benefit. It did not happen. So they gave it together with chemotherapy. Unfortunately, those trials, and I'll show you one of the trials we did, and reduces cost again by the need. This is why Medicare approved it. It's because it decreases the need for recurrent radiotherapy, because radiotherapy you have to keep coming back and forth. Reduce narcotics, and especially the largest cost would be hospitalization. So that's what you need. This is 2 papers were done. One, the most recent one is 2014, where they followed this is the Anderson trial, where they gave strontium-89 after chemotherapy. It crossed over. There was no survival benefit. The larger trial showed no survival benefit, so that's why it's palliative. They were given together with doxorubicin or doxorubicin alone. You have to randomize the patients. Some get the saline, some get strontium-89, but it didn't pan out. The other tracer which is approved for us is samarium, EDTMP. You have samarium available in the countries. You have samarium, yeah. Quadramet. It's, as I said, it's just like MVP. Distribution is like bone-seeking agents. 2-day half-life, so the patient has to show up on time. The other advantage of strontium is, they get caught in traffic or the car breaks down. The date is up. They can come the next day. It's still good. But the strontium, the samarium is not as forgiving. Beta, 0.58, range is shorter range but higher delivery. And you can image them. It has a 1.03, 103 keV gamma. The beta you can image with bremsstrahlung, but the bremsstrahlung image are like, you need to be have an artistic interpretation. The scans are not very, very high quality, but the EDTMP has the samarium is very nice. So the dose is essentially 1 millicurie per kilo, so it's about 70 or so millicuries. The platelet nadir is about, as I said, 4 weeks, about a month out. Bone marrow suppression is usually mild, no grade 4, requiring intensive transfusion and treatment. And it's reversible. And the counts usually recover, by 2 months. So first month it goes down, by second month it goes back. It has been used for treatment in osteosarcoma. We thought if men can use it for prostate cancer, you can use it in combination with chemotherapy. And again, radiation therapy has been used for osteosarcoma as well as metastatic disease. The problem with metastatic osteosarcoma, it goes to multiple sites, both bone and usually the pulmonary metastasis. But the the good thing, well, it's not a good thing, the advantage is if you use radionuclides like this, the pulmonary metastasis, soft tissue metastasis, including in the soft tissues in the muscle, is calcified. So they also pick up the MBP. So that's why you can actually try to use it for therapy. And again, Peter Anderson, who used to be with us, led the trials both at the Mayo Clinic and then at Anderson and now at Duke, where they give multiple treatments. We gave very high doses with chemotherapy and stem cell support. There is a radiographic response both on the bone scans. However, the durability of the response, they tend to break through and still progress afterwards. Part of it is what we've seen with the alpha therapy, which I'll show you later, is that there is a component of the osteosarcoma which is non-calcified, so it doesn't pick it up. So it is not enough to kill all of the cells who are not in a calcified position, in our opinion. So the palliation can be done on the bone-forming sites with RT for control of unresectable. So it could be used for palliation in patients who essentially, off-label use for us is patients who have metastatic disease, positive on the bone scan, who need pain palliation. You can give samarium, even if they have visceral metastasis. Because the visceral metastasis, like osteosarcoma, can also collect or retain the tracer. This is just an example of samarium EDTMP. This is a patient who has obviously pulmonary metastasis from a metastatic osteosarcoma. This is a recent meta-analysis, if you like these types of trials. 13 randomized, 23 prospective, 10 with strontium, 7 with samarium, 12 with rhenium, 2 with rhenium-188, and a couple of phase 2, phase 3 trials with radium. There are very few blinded studies. The blinded studies tend to be the later ones, including radium. The pain response, as I said, is about 60% for us, 50 to 60% seen with each nuclide. They're all affected. In over half of the patients, you will get a good effect. The primary toxicity was hematologic toxicity in nearly all the studies. The ones which don't have hematologic toxicity are usually the alphas. Greater than half of these trials, there was not even grade 3 or 4 leukopenia, white cells reduction, or thrombocytopenia. It's not as toxic as the other tracers, and it's a single administration. And you can repeat them. As I said, 90 days for strontium and as well as samarium. There are newer agents which have been tried, at least in pilot. We don't have randomized, long-term, large-scale, 2-to-1 trials. The problem we have had in nuclear medicine, all of our trials are usually single-center retrospective analyses. This one was done with Germany. Fred Giesel will be here. He can talk about all of their trials, but this is one with PSMA with I-131. I mention it because if you don't have lutetium, it's very expensive. I kind of like the more practical solution, because iodine, we are familiar with halogen chemistry. Iodine-131 is not as expensive. So I think you have a session on I-131 Rituxan and how to label. So one to consider was I-131 PSMA. In the trial they did, it's a pilot trial, they have shown responses in both the lymph node and bony metastasis, which shown some at least early response to these agents in PSMA. I mentioned the PSMA because the tracers we've used for, what we discussed, is only goes to the bones. But prostate cancer can go to the lymph nodes, to the liver, and sometimes the lungs and CNS. It goes everywhere, so you have to consider it. Another interesting one, of course, is the lutetium PSMA therapy, which Richard Baum has just published very recently This is 3 doses of lutetium PSMA showing a response. Again, this is single center. You select the patients. You don't have patients being recruited, and I'll show you how to do it. The best way to do it is to do it with your medical oncologist. You have several types of patients: little disease, moderate amount, extensive, and those with widely extensive superscans. So it's been done. It has shown some effectiveness. And again, this is with gallium 68 PSMA before and after therapy, and then you have the intervening treatments. But if you look at it, aside from the bone, if you look at these therapies, you get a lot of kidneys, right? You have to worry about renal toxicity, sialadenitis, just like in the iodine. You can have a fair amount of bowel and liver sometimes, so you have to worry about these toxicities. So our experience is not that good. We have experience in lutetium more for the neuroendocrine tumors in our center, but it is certainly interesting. Yes? I'm sorry?
The dose for the lutetium.
Oh, I don't know exactly how much they gave for the PSMA.
No, those 200 millicurie like.
No, not that much, not that much. And you have to pre-treat with amino acids prior to giving them. You have to give them some drugs, sometimes like Benadryl, to make sure they don't get any reaction also. So it's a different subset. I think I'll have Fred Giesel next week, because he gives PSMA therapy for prostate cancer. I'll let him discuss that. I don't like to discuss things which I know of only by knowing the numbers. So, but it depends on the dosimetry which you want. And again, I can tell you with great certainty how long this will last, if there is a overall survival benefit. Because when we looked at the original data from the other beta therapies, they show improvement radiographically, but the survival is what's important. You have to follow them and make sure they live longer than people who do not get them. And this trial, the trial I showed you, is not randomized. You need to give water to some people to make sure they're similar, to show proof that it actually helps them survive. Because I think it's important for us to move beyond palliation, but to actually give survival. What makes us relevant is if we can give a drug which can make people live longer. Because a patient will say, I'm in pain, blah, blah, blah. Can this help me live longer? That is more, that is a primary thing. Okay? For thyroid cancer, we also want to treat them. You want to make sure that in patients with differentiated thyroid cancer, you have to search for bone metastases. And the search is usually done at the time of initial evaluation for radioiodine therapy. And if they have skeletal related events, they present with more. So if they have bone metastases, you have to make sure you find them so you can avoid pathologic fractures and cord compression. So the beta therapies also apply to it. First line therapy is radioiodine. If it doesn't pick up iodine, it's usually a bad thing, because the iodine can palliate, it certainly cannot cure. The responses we see are more with younger patients. They have smaller metastases, and they're usually FDG negative. So those are the patients which usually get the best responses for these bone mets. The second line we give was when radioiodine is not effective, they get more pain, is rapid local control with PEBRT. You can convince your surgeons to do metastasectomy. If there's solitary metastasis, you can do it. But now we actually do more minimally invasive techniques, which would be percutaneous techniques like RFA or embolization. Usually denosumab is the better agent, the rank ligand inhibitor denosumab. In lieu of zoledronic acid, we prefer denosumab as used. This is a review by our medical endocrinologist for thyroid cancer. So denosumab could be used. So again, radioiodine first. Your local control with radiation therapy. If it could be surgically excised, it should be considered. You can't radiate, you can consider minimally invasive interventional techniques, and systemically you can use bisphosphonates. And usually we have our endocrinologists give the bisphosphonates. So if you treat them, it should be employed if there is uptake. The empiric dose we use is about a couple of hundred millicuries. It's probably less if they are younger patients, etc., or they're quite debilitated. And usually we tend to admit these patients with such high doses. You always consider multi-therapy. Don't just give iodine. You just evaluate the patient. In patients with whom surgery or radiation is feasible, or interventional techniques to treat them. And again, denosumab is an agent which should be considered like these bone-directed agents. It increases the bone density of these patients. One of the most common procedures we do, or the most common procedure we do in our nuclear medicine clinic is no longer the bone scan. It's actually bone mineral density. It's all patients who get systemic therapy, radiation therapy, combination therapy, including thyroid cancer patients who get thyroid hormone suppressive therapy, are susceptible to low bone density. So that's the one thing I encourage you to have, is to have a bone health section. So the prevention and the monitoring is with bone mineral density. We look at them and we laugh at them because they're kind of like ATMs, you know, because they're all over the place. Every outpatient clinic has one of them, and all of the patients need at least one every year because it gives us a trending of whether they need to adjust their bisphosphonates or their rank agents. Okay. A few examples. Thyroid cancer tends to be not like prostate or breast cancer to be not quite as sclerotic. You might not see as much activity on a patient with thyroid cancer on the bone skin. But you can have solitary activity and you can treat them with radioactive iodine. So you don't treat with, you know, if they're solitary like this, you can do an MR and you can localize it. You can either treat with radioactive iodine, but also consider external beam radiation as a possibility for these patients if they have solitary lesions like this. Another one, this is on like unsuspected osseous metastasis up front, thyroid cancer, metastatic to bone. The other thing I'd like to mention, in case you don't know, there's what we call the Mirel scoring system. If you get a score of 8 or greater, this lesion may be susceptible to fracture. So you score 1, 2, and 3 each of these findings. So you get a score of 1 point if it's the upper limb, 2 points if it's the lower limb, or the peritrochanteric in the proximal femur, it's 3 points. If there's pain, mild, moderate, or none, it's a functional pain. They can't move it anymore. It's 3. So you have a lesion which is blastic, lytic, or mixed. Mixed is actually a 4. And again, the size is how much it involves the marrow cavity. So this is an example. This is an impending pathologic fracture, but this is of course a lung cancer patient. They tend to be lytic. Lesion is greater than 2.5 cm in length, more than 50% of the diameter of the bone. So more than 50% is about the 2, sorry. The Mirel score is actually 10 because 3 points, more than 2/3 is 3 points. Lower extremity, 2 points. Moderate pain, 2 points. And fracture is considered likely to occur without intraoperative intervention. So they tend to put a intramedullary nailing to support this. If you radiate it, it becomes more sclerotic. These are lesions if you don't want to nail them, but if you want to treat these pathologic fractures, this is something you need to consider. So again, in summary, if you're going to treat, it depends on the type of tumor. The prostate and breast cancer you can treat with strontium or samarium. Sometimes you can use it in an off-label use for treating patients with metastatic sarcomas of the bone. When you treat them, it should not be solitary treatment with the beta therapy, with the radionuclide, but it would be systemic in combination with bisphosphonates. And you have to consider local therapies, either with radiation therapy or minimally invasive techniques with interventional techniques, and be on the lookout for pathologic fractures so they can be fixed by the orthopedist. Because in the end, you want to keep your patients going. If they're going, you have somebody to see and treat. If they get immobilized, and that's the end of the story. They get infections, etc., and everybody is unhappy, including especially the patients and the immediate family. Now, any questions before we go on? Yes, sir. Yes, sir.
It's lasting for how many days?